Alright, so we're going to talk about assessments in this section. So hopefully it'll kind of help you prepare for National Registry a little bit better. My name's Amber. I have spent 18 years in EMS as critical care paramedic. We've done a lot of rescue in large, very heavily populated areas. I went on to school to become an RN, and I currently work in an ICU. So thank you for joining me again. Alright, so the beginning of our assessments really actually starts at the time of dispatch information. When you get your initial call, like, you're going to start thinking of best case scenarios and worst case scenarios and any protocols that might be associated with those, and kind of probably anything between. So you're going to want to think about, like, definitely the worst case scenario. Like, if you show up on scene, like, what's the worst thing that could be happening with this patient? So I'm going to give you kind of an example, and hopefully we can it'll give us a little bit of basis or background. So you get called for a 50-year-old male that is unresponsive. That is all you have. We don't know if he's breathing. We don't know if there's pulses. We don't know anything besides the location of the patient's, where the patient's at. And in this scenario, we'll just say that it's a single residence home. So when I get an address, typically I like to be in the back. I don't mind driving, but I just don't prefer it. So, and usually my partners are pretty chill about that. If they're not, then I'm flexible. But so, like, the first thing that I start thinking about is, like, what are like the biggest causes of what could be going on with this patient. It could be in cardiac arrest. It could be drug use, or toxins, one or the other. It could be illicit drug use. It could be something like carbon monoxide poisoning, things like that. Depending on the time of year, we could have some issues with hypothermia, or even if it's hot, we can have issues with weather-related events and heat-related emergencies, things like that. It could be trauma-related. It could be sepsis or other infections like pneumonia. And then hypotension associated with those things. So we have to just kind of start thinking about, if this patient is in cardiac arrest, just keeping everything organized in your head, and of course making sure that everything stays calm and, you have a good control of the scene and environment. Okay, I kind of talked about this in the last section, but we'll kind of touch base a little bit more on this. Weather-related events and situations for patients. Like, obviously we talked about, like, cold emergencies, but, like, an important thing to remember is that even if it's, like, 60 degrees outside and we have, say, for example, a homeless person that is sleeping outside, like, that can still be a hypothermic event because, 60 is much cooler than our body temperature, and depending on where this person is sleeping or, like, just kind of the environmental situation, like, we can have nice evenings and still have a patient that's hypothermic. Also, just the temperature. What temperature is it? Is it cold? Is it raining? Is it hot? Is it just a damp, chilly, kind of foggy type of day? So just kind of keep those factors in mind. So usually when I'm on the way to a call, sometimes they'll give you information, but sometimes not. So and it all depends on like the dispatcher that's getting the information and the person that's actually giving information, like the caller, the person that called in. But a lot of times I'll look up, like if I'm not familiar with the building or the location of the address, I'll look it up on Maps or Google and just kind of get an idea of how many stairs there are. Is this in the middle of a house in a really rural area, or is this a house in the city? Is some of the places that I provide EMS services for, like it's kind of a mixture of both. There's some locations that are kind of just way out there. They're kind of in the middle of the dirt roads, and then we have other places that are really close, much closer to the hospital. So you want to start thinking about like what hospital are you going to transport to if you have to transport this patient. Is this location at a grocery store or another public space like a gym or community center? And then, is this patient located outside? Are they located inside? So just start thinking about those things when you're responding to your calls. So this is kind of something that I've developed as a paramedic. They don't typically teach this in school, but it's useful, and I'll kind of go into it. So the assessment triangle, it allows you really to it kind of trains you to start looking at your patient from a distance before you even get close to them. So you find your patient, usually they start teaching this for pediatric assessments, but really you can apply it to all of your patients, and it'll be really, really actually beneficial. So let's see. So the purpose of this is just to kind of be able to evaluate and assess your patient before you even get close to them. You're going to look at the patient, and are they breathing? Are you seeing chest rise and fall? Are you seeing, what color are they? Are they responsive? Are they sitting up? Are they laying down? Are they struggling to breathe? Are they, what color are they? Is their skin, are they pale or really flushed? Or are they diaphoretic? These are all processes that will start bringing you into a more stable assessment pattern. I touched base on this just a little bit in the last slide, but we're going to look at the patient's work of breathing. We're going to look at the appearance of the patient, and we're going to look at circulation. So work of breathing, are they labored? Are they not breathing? Are they tachypnic? Does it look like they have agonal respirations? Their appearance, are they tripoding? Are they using accessory muscles to breathe? Sometimes it's kind of hard to see that, so you'll have to really look, when you get close to your patient, you'll have to start assessing that, for supra and subclavicular retractions, intercostal retractions, things like that. And then circulation, you're going to look at their skin color. You're going to look at, to see if they're pale or, just kind of what color is their skin, how are they perfusing. And cap refill is also an important tool. Once you kind of start just doing a quick assessment and just check cap refill, and it kind of just helps you have a better picture of the actual perfusion, even apart from a pulse ox. It'll give you more information. So we talked about this already, but just to kind of give you a little bit better of an example, or talk about the pulse ox a little bit more. It's a really good tool, but the problem with the pulse ox is it literally attaches to one single hemoglobin. So it doesn't really tell you, like, it tells you, yes, oxygen or something, another gas. It could be carbon monoxide even, and a pulse ox will read carbon monoxide as 100%, even though they might not have actual oxygen attached to their hemoglobin. So basically, like, carbon monoxide has a 7 times affinity for attachment to the red blood cell, essentially. So carbon monoxide will attach 7 times easier to the red blood cell than oxygen does. And unless you have like a specific like pulse oximeter that reads carbon monoxide, which typically it can kind of be rare to find those because they're pretty expensive in the world. But so just keeping that in mind, if you have a standard pulse ox, like it's just gonna read, like, it can read other gases as well. So and also it doesn't really tell you if your patient's anemic. Like I said, like it only needs one red blood cell to attach to read. So essentially, you might have a patient that's anemic and doesn't have a lot of red blood cells. So it doesn't give you any information beyond a percentage number. Again, a good tool, but just be aware of, kind of the downfalls of a pulse oximeter. So just kind of continuing assessing your patient, like, where's the patient? Like, are they sitting on a couch? Are they standing and pacing and anxious? Sometimes respiratory distress can cause anxiety. So these patients might actually be like pacing around or just sitting on the couch, and, like, they might be visibly anxious. So once you kind of hopefully correct that problem, or at least begin to correct that problem, like, the patient's anxiety will like improve. But another factor that we need to like kind of consider is like, how is the work of breathing? Like, like, you can have a patient that's got a 96% oxygen level, and that's totally fine, but they're working so hard to get to that 96% oxygen level. Is this patient going to become fatigued and go into complete respiratory failure? You have to think about that. So, in those instances, BiPAP or CPAP, whatever you have available per your protocol. Typically, the most standard is you'll find is CPAP on the ambulance, and of course follow your protocols when it comes to CPAP. But if you have a patient that's not responsive, do not put them on CPAP. Don't do it. It's just bad. They could aspirate, and it's just a bad day. So if that patient is that sick, you need to bag the patient, or you can intubate the patient based on your protocols, using RSI, or rapid sequence intubation. So just keep those things in mind, and obviously follow your local protocols when it comes to RSI and CPAP. But just be very careful. Like, CPAPs do vomit. CPAP patients do vomit. I've seen it like probably more times than I'd like to count. So in the ICU especially, like, I've seen it like countless times. Well, so these patients do get really sick. That CPAP can push air into their stomach instead and cause vomiting. So just, if you're concerned about them not maintaining an airway, like, definitely avoid like CPAP. Alright, so OPQRST. They make it really easy, don't they? Like, you can't beat that. It's like in order even, so. So this is an assessment that's typically used for medical assessment, but it can be for pretty much anything. Just use your best judgment on that one. It can be used as a tool for pain and, just other complaints too. So, onset. What were you doing when this pain started, or this whatever medical complaint that you have is going on? Does anything make this better? Does this make this complaint better? Like, does anything make the pain better? Is there a position that's better? Does moving make it worse? Things like that. Quality. So describe the pain. Like, is it sharp? Is it aching? Is it like a dull pain? Is it stabbing? Things like that. Those are important evaluation tools. Radiation. Does this pain or whatever this complaint radiate to another part of the body? So, if you have a patient that has chest pain, is it radiating down their left arm? Is the pain going into their shoulder or back? Is it going up into their neck? Things like that. Severity. How severe is this pain? Like, does this patient, it's like meh. It's like a 2. It's fine. Like, it's mostly fine. Like, I wouldn't even take Tylenol for this on a normal day type thing. Or is this like the worst pain that could ever happen in their experience of life? Is this a 10 out of 10 pain type thing? And time. Like, this is a really important one that we need to definitely make sure we remember. Time is important for chest pain calls. It's important for unresponsive or altered mental status calls. Just so that, like, the physicians, more likely they're going to want to do a head CT for an altered mental status patient. And if it is a stroke, it's important to, know their last known normal time. Okay. So for unresponsive patients, what is the criteria? Do we use ABC, airway, breathing, circulation, or do we use CAB and start with circulation assessment? There's 2 criteria, and this is kind of how I remember it in my brain. If you have a cardiac arrest patient, you're going to use CAB. And if you have a trauma patient, you're going to use CAB. Reason being, if you suspect cardiac arrest, you don't see chest rise and fall, more likely this patient's in cardiac arrest. At best, they might have a pulse. And if they do, then you're going to start with the airway. You're going to open the airway and continue your assessment that way. Start bagging the patient if they don't start spontaneously breathing on their own. Also, for cardiac arrest, you're going to use circulation, airway, breathing. Trauma patients, the reason that you start with circulation, if this patient's bleeding out, it doesn't matter if they're going to have an airway or not. If they are losing all their blood, they're not going to. It's not sustainable to life. So, you want to be able to keep them alive before they go into a cardiac arrest situation. All other calls, scenarios, you're going to use airway, breathing, circulation first. And I'll let you guys kind of read through the rest of this, but basically it's just going into circulation, airway, and breathing. If the patient does have a pulse, you're going to check the carotid. It's the most reliable location. And don't check it for longer than 10 seconds, because if you don't feel something in 10 seconds, that they probably don't have a pulse. And obviously you've already checked for your responsiveness, so if the patient's responding or not, and then you're going to check for your pulse, and then you're going to check for your, start your CPR. Airway-wise, if the patient does have a pulse, open the airway. Sometimes it just takes a simple head tilt, chin lift. And if there's trauma, you're going to open the airway using the jaw thrust. So you're just going to pull the jaw forward without moving or hyperextending the neck. And even with C-collars too, it kind of gets a little dicey, because if you have a C-collar that's like not fitting a patient well, use your best discretion, but you don't want to hyperextend the neck too. So that could just, do more damage if something is damaged. So you can always secure the head in a different manner using towel rolls or, like the foam blocks, things like that. And you can always talk to your local, ER physician too, and just kind of see, what they prefer for their patients. I've used towels and sheets, rolled up sheets before even, so just follow your local guidelines and protocols, and usually there's some kind of alternative method if a C-collar is hyperextending the patient's neck. Sometimes you get those little patients with kyphosis and things, and they've got that little humpback, or they just have short necks and things like that, especially the smaller little older people that kind of deal with osteoarthritis a lot. So there's that. So we talked about airway, breathing, circulation. D refers to disabilities, so basically it refers to the patient's neurological status. And then E is, consideration of cold, heat, and various environmental exposures. When you have a cardiac arrest patient, your protocols do change for hypothermic related events. So just be familiar with that. Typically, the saying is, they're not dead until they're considered warm and dead. So, if they're that cold, there is a chance of resuscitation. So just be sure to be familiar with those protocols, especially when you live in the colder states, towards the north and the east coast. So DCAP BTLS can be used, it's mostly used for trauma, but you can assess tenderness is an assessment that you can utilize for a medical concern. So D is for deformity. Are there any severe deformities noted to an extremity, or that would be probably associated with a potential fracture? Contusions, those are bruising. That's just basic bruising. So if you have a contusion on the abdomen, it could be seatbelt related in the instance of a motor vehicle accident. And if you notice contusions or bruising along near the liver, that could indicate a bruise or bleeding from the liver from trauma. So that would obviously escalate this call into a much higher priority than prior to this assessment. Abrasions, these can happen when you have a fall, a trip and fall. You can scrape your skin, just scrape basically. Or can be often associated with road rash from motorcycle incident. Punctures or penetration for P, those could be a dog bite would be a puncture, or a penetration could be say for example, and this is probably an extreme case, but you have a patient that they were riding their motorcycle and they hit water or puddle or something and flew off their motorcycle onto a fence post. That would be an example of penetration if that fence post was inside of their body. And do not remove the fence post from their body, please. Just, you're going to need fire, you're going to need things to cut metal, but removing that metal or that post or that bar from the patient's body can cause uncontrolled bleeding that you cannot manage without surgical intervention. So you definitely don't take things out. If it's there, it's there and it's staying until a surgeon can see that patient. B stands for burns. So if you have a patient that has burns, you're going to follow your protocols on that. Depends on how severe they are. You might be required to utilize a sterile dressing, a wet to dry type of dressing, or just a basic dry dressing for like minor burns, just to cover that area and protect it from any exposure to bacteria or germs. Tenderness, this would be an example of, like if a patient's complaining of abdominal pain from a, post car accident situation, if they're complaining of abdominal tenderness, it's definitely something that they're going to want to get checked out. And, so like when you do your assessment, you're going to start on one side and you're going to lightly palpate. And then you're going to work each quadrant. And then the next palpation is going to be a little bit more of a firm palpation. And that'll just help you further assess, like, the patient's status. If there's bruising that's associated with an MVA seatbelt type of injury, like, you could have a liver laceration, especially being that fast. Typically, bruises start to show up a little bit later. It takes a little bit of time to start seeing that, but if you're seeing that unseen post-car accident, this is probably going to end up turning into a much higher priority than maybe even initially expected. And then you have lacerations. So L is for lacerations. Just control bleeding at any point. We have use of, pressure bandages, elevation, ice, and lastly, just utilizing a tourniquet if that's, what it takes to control this bleeding. And tourniquets aren't fun. They're not comfortable. They're actually kind of painful, but it'll save that person's life. So you're just going to have to help kind of provide that emotional support for that patient. And then lastly, S stands for swelling. Is there any significant swelling to an area of injury? I also just wanted to thank you guys for taking the time to watch this and visit my channel. I am working on a cardiology unit or chapter coming up, so obviously it takes a lot more information and organization to provide that. But do come check back. Hopefully I'll have it ready for you guys in the next week or so. Thank you.